Thank you. Good afternoon to all. Happy to see you now. Today, as senior said, today we are going to learn about gastrointestinal symptoms. So that is on part one, nausea, vomiting, and constipation. This will be taken by Dr. Gauraiya. She is a palliative care physician. She did her MD palliative care, palliative medicine from Tata Memorial Hospital, Mumbai. She has a Bruce Davis Gold Medal winner in 2014 from Institute of Palliative Medicine. Now she is an assistant professor at Homi Baba Cancer Hospital, Tata Memorial Center, Varanasi. She has a lot of experience in palliative care. Welcome, ma'am, and over to you.
Thank you for the introduction and hello everyone. Just there was a little problem. I was in Homi Baba Cancer Hospital in Varanasi, but currently I work in Indore. So let's start.
Okay, ma'am. Sorry, we didn't get that
No,
updated.
that's okay.
Sorry
That's
for that.
totally fine.
Okay, thank you, ma'am. You can go now. Start now.
Yes. So just let me know if my screen is visible to everyone.
Yes, ma'am. Just go for that slide sharing option.
So can you see the slide and if it's changing?
No.
Oh. This is the issue which happens. So I think you'll have to put on the presentation from your end.
Yes, ma'am. We can do that for you.
Vomiting and constipation. Let's start with nausea and vomiting. So we have so many different terms. One is nausea, one is vomiting, one is retching, and another is regurgitation. So can anybody of you tell me what is the difference between the four? Or can you just elaborate what these four things are? I'll repeat what is nausea, what is vomiting, what is retching, and what is regurgitation. Anyone can answer. Or even if you know just one, that's also okay. You can actually unmute and talk also. Right. So I think we have two things. Yeah. In the chat. So yes. I don't know. I'm not able to access the chat option, but yes, the answers that I'm getting, they are all correct. So yes, food that came back after eating is regurgitation. So it has actually not passed food or any other gastric content or any, you can also say not even food, sometimes only the content of the stomach, they come out, the enzymes or just secretions, and they can come out via nose, they can come out via mouth. So both of these things, so this is called as regurgitation. Nausea is just the unpleasant feeling. So it is an unpleasant feeling of the need to vomit, and it can be accompanied by pallor or cold sweat or salivation or tachycardia. But when the actual thing happens, which is like forceful expulsion of gastric contents, which can be food or water, through mouth, specifically through mouth, so that is called as vomiting. Retching is rhythmic or spasmodic movements of diaphragm and abdominal muscles, so that would be retching. And regurgitation, as I said, it is backward flow of incompletely digested food or liquid, and it can be into the mouth, or it can be into the nose, or it can be into the pharynx as well. So the difference here is regurgitation can be into the nose and pharynx as well, while vomiting is through mouth. Nausea is the unpleasant feeling, and retching is like spasmodic movements of diaphragm and abdominal muscles, which later on lead to vomiting. So I hope we have the difference between these four terms. And let's move on to the next slide. And this is common in patients of cancer, palliative care. In fact, so many patients in all fields, and even we experience nausea and vomiting most of the time. So it's important that we know about these specific terms, meaning. So when we are talking about this, the most important thing when we are talking about nausea and vomiting is we should know the cause. Like what do you do when there's a patient with nausea vomiting? Like we just most of the people, what they do is they prescribe, they have a favorite antiemetic and they prescribe that thing. But before that, we should look at what could be the possible cause for this, because there are many causes and many different pathways which are related. So next slide, please. Right. So you can just keep on clicking del. Yes. No. Wait. Right. So the first one, the most common cause of nausea and vomiting we encounter is metastasis, because we are talking about cancer patients. And metastasis can be like, it can be metastasis has like reached to liver. So there could be toxin buildup, and that's why patient could be feeling nauseous, and patient may vomit also. Second could be because there is metastasis in the brain. So there is raised intracranial tension. So these are common causes for any patient who might be having metastasis. Second is medications. So there are medications, most commonly opioids, which cause nausea, vomiting. Then it could be because of chemotherapy. It could be because of radiotherapy to specific parts of the body. So can anybody tell me, like, which is the most common part of our body where when radiation is given, it causes nausea and vomiting? Maybe you can unmute also and give your answers. No one? Right. Brain and bowels. Yes. Anywhere else? Okay, so whenever radiation is given, so yes, when it's given to the brain, yes, there is nausea, vomiting anywhere on the abdomen or lower abdomen or pelvis. There is nausea, vomiting, but if it's given on extremities or over the thoracic area, there are mostly on over extremities. We don't expect nausea, vomiting, and over thoracic area usually it's not there. So it could be because of radiotherapy, then it could be because of NSAID, very common. Everyone gets acidity because of steroids, because of antibiotics. So whenever you see a patient who is taking dexamethasone, prednisolone, and paracetamol, so he could be having acidity, and that's why he could be having nausea and vomiting. Next, the next reason could be movement. So here we are talking about motion sickness and vestibular stimulation. It can happen in palliative patients as well as other patients also. The next one is the reason is mentation. So um, this is, have you seen a patient who has been on chemotherapy, like he has received 3 or 4 cycles of chemotherapy and he's here for the next cycle, and even before the chemotherapy is administered, the patient will start vomiting. So in this case, it is because of anxiety or previous experience that the patient has. Whenever you give chemotherapy, it may lead to nausea, vomiting. So this is because of the cortical activity, and this we call as, the reason is mentation. Next one is mechanical. Yes, so there could be constipation, and there is blockage in the bowels, and whatever you are the patient is putting in through the mouth, it doesn't have space to move out because of constipation. There is stretch of the lumens and the patient is vomiting out. Then there could be tumor or stricture in the wall, And we have three things. So one is luminal, where there is something inside the lumen. Then because of the wall, so there could be tumor or stricture of the wall of the bowel. And third is extraluminal. So there is something which is compressing on the bowels from outside. So it could be peritoneal deposits. And because of this, there is no place for whatever patient is eating to move downwards or outwards. And because of this, the patient may have nausea and vomiting. The next cause that we have is metabolic. Now, metabolic is electrolyte disturbances. So most common we see is hypercalcemia. Patient may have high calcium, low sodium, and there could be very commonly liver failure, kidney failure. So you can see patients with high serum uric acid, urea, creatinine, and in patients of liver failure, all of their enzymes have raised, bilirubin, total, and like conjugated, non-conjugated, everything is increased. And this can be because of liver failure, can be because of metastasis in the liver or in alcoholic liver disease patients. And kidney failure can be because of various reasons. For example, in patients of CA ovary, like there is tumor which is compressing on the kidney, or because of general patient is going down because of toxins in the body, ultimately kidney also starts to fail. Or in patients of CKD, when we are talking about not about cancer, so patients of CKD, so CKD or even CLD, that is chronic liver disease, chronic kidney disease. So these patients may also completely like usually they frequently complain of nausea and vomiting because of toxin buildup when liver and kidney they are not able to work. Otherwise, hypercalcemia, hyponatremia, this is very commonly encountered in patients who are on chemotherapy, who take in lots of fruits or have kalemia also. So any of these electrolyte disturbances can cause metabolic problems in the body and can lead to nausea and vomiting. Then next one is mucosal. So we talked about drugs causing acidity and nausea, vomiting. So here it's somewhat similar. So patient could have acid peptic diseases because of a lot of acidity. Patient could be on NSAIDs. Patient could have gastroesophageal reflux disease, and this can cause ulcers, mucosal ulcerations, and that's why patient could have acidity and ultimately nausea and vomiting. So if you see patients who complain of pain in the throat and along with nausea, vomiting, so you can say that yes, the pain in throat is because of it happens because of acidity, and then patient may have nausea, vomiting. And lastly, we have because of microbes. So this is common. Patient may have infection, may have food poisoning or typhoid or systemic sepsis also. So, or could have like oral cavity infections also. There could be infected mouth ulcers. There could be candidiasis. And because of this, patient may have nausea, vomiting. So here we have like 10 causes most common of nausea and vomiting in palliative medicine, and they all start with M. So you can say they are 10 M's, and that's how it will be easier for you to remember these 10 causes of nausea and vomiting. So next slide, please. And this is important because when you actually look at the history or just see general things associated examination of the patient, so we are able to somehow guess what could be the possible cause of nausea and vomiting here. So when we're looking at the quality, so is the patient only feeling nauseous? There are some patients who say ki, whenever we see food, we get this smell and we feel nauseous. And they don't actually vomit out everything, but they just feel nauseous. So that could be one cause. There could be cerebral cortex involved. There could be chemoreceptor trigger zone involved also. So we should know whether patient is feeling nauseous or just he's actually vomiting also. Then the duration, frequency, like patient may vomit just once and would complain, I'm vomiting, there's lots of problem. And there could be somebody who is vomiting 10 times a day. So we should know. Then contents are important because sometimes we can guess the cause of nausea, vomiting. Sometimes it's like feculent, black colored, sometimes it's red, sometimes it doesn't have food content, it may have food content. So we know where this nausea, vomiting is coming from, the part of the body. So contents are important that way, to recognize where this is coming from, and so that we know what is the cause. Then coming to associated factors like pain. So this could be because of mentation, right? If the patient is having so much pain, he will have tachycardia, he will have sweating, and along with it, he might have nausea, vomiting. So the major problem here is pain and not nausea, vomiting. It is an additional symptom. So we need to look at it by that point of view also. And you also need to look at altered bowel habits. Very commonly, we see that patient has constipation, he has not passed stool for 4 or 5 days, maybe even more, and then he says, I have nausea. So the simplest remedy here would be to relieve him of his constipation and he'll be fine. And there could be temporal variations, like a patient may feel like we commonly know for morning sickness, it is morning, but that is not like it is in pregnancy. Not all of our patients are usually suffering from any cancer during pregnancy, or like they may not have diseases, but then yes, sometimes patients eat and just before like after eating they have nausea and vomiting. So you know that there could be obstruction below the stomach but before the intestine. So that way we might know. And there could be aggravating relieving factors. So he could be whenever the patient comes to hospital, he could be having nausea, vomiting because of the place, and he might be anxious, and he could have the problem. So you need to look at, it could be anything ranging from, it could be place, it could be how the patient is feeling, or the uh, like it could be anything. These are two examples, I cannot remember like more right now. And you also need to have a look at the medical and drug history. It is very much possible that he is on 10 medications, and 10 medications which have interactions, and also some of them might be causing acidity, some of them might be causing constipation, some of them are like opioids, that they slow down the movement of the bowel, and that's why they cause the symptom. So we need to have a look at this also. And all these things together, they just tell us that this could be the possible cause, and that's how we go on to relieve the patient. Then you can see the abdomen. For example, patients who have bowel obstruction, so they could have a abdomen which is like, you can see it's full and tense abdomen. And when you if we see what the rectal examination, we can have fecal impaction also. And those patients who have microbial infection, or maybe liver failure, they could have signs of sepsis and neurological signs as well. So those patients who have liver failure, so we see so many signs which are related to liver failure, and we know that yes, all this nausea, vomiting is most probably because of his liver failure. And the most common investigation that we do, which is easily available, cheap, is X-ray abdomen. So we make the patient stand and get an X-ray abdomen if we want to see whether there's obstruction or there is fecal impaction. So usually X-ray abdomen erect is done, and here we'll be able to see air fluid levels when the patient is standing straight. If the patient is like sleeping and then we do an X-ray abdomen, then we won't be able to see the air fluid levels very clearly. Though fecal impaction or feces or any other mass in the bowel, that is easily visible even if the patient is sleeping. And then if you have more facilities, or if you're not able to diagnose on X-ray, you go on to CT scan or MRI. And obviously, along with all this, we can do relevant blood tests. So we can check for patients' sugar, sodium levels, potassium levels, calcium levels, kidney function, liver function, CBC. Patient could be having raised WBC counts and sepsis. So all these things, whatever you feel like this could be the cause, you can correlate the relevant blood tests, and you can we can guess that this could be the come to a differential diagnosis that yes, this could be the possible cause. So that is the importance of history and examination, so that we know how to relieve the patient, what possible treatment can be given. So next slide, please. Next, please. So first, we have identified, or we are trying to identify the likely cause. We know what are the common causes, and we know what history or symptoms that we are seeing in the patient could correlate. And now we are looking at the pathways or the neurotransmitters involved. This is also important because we need to know what possible treatment is required. So next slide, please. So there are mainly three key players. The first one is GI tract. So you can click once more, and one more. Yeah, click all of them, right? So they are like, the first one you can see is the GI tract here. So it involves stomach and intestine. The second one is the brain, and the third one is the ear. So we have one center in the stomach and intestine, we have three centers in the brain, and one center in the ear. And all of these centers have their specific receptors. And it's important that in the brain we have the vomiting center. So the whenever something happens in stomach or intestine or in the ear, the signals are always passed on to the vomiting center in the end. So if cerebral cortex is activated for nausea vomiting, it will also send to vomiting center. Same for area postrema, same for vestibular apparatus, and same for stomach and intestine. So this is usually the last in the pathway. And if obviously something is happening in the vomiting center, so this is the first and the last. So this is the center from where all the signals are passed on, and this will cause first nausea, and then it will cause further signals, and then there could be like the contents will be retrograde flow, and the contents will be thrown out. And why we are talking about all this is because there are specific receptors in each of these centers. And whenever we think of a cause, we should be next think of the centers from where that cause is originating. And when we know the center, we know that yes, these are the receptors which are present on that center. And if we want to treat this particular cause of nausea vomiting, then we have to give a medication which acts on the one of the centers. For example, let's take the example of cerebral cortex here. So like I talked earlier, a patient who has received chemotherapy twice, he comes to the hospital for the third time to get his chemotherapy. And even before it is administered, he starts to have vomiting and he feels nauseated. So this is cause we talked about as mentation. And this is mostly because of the cerebral cortex, because he has this memory. And because of the memory and previous experience, he starts to have the nausea vomiting. So if we know that, yes, a patient has already started vomiting, could be because of cerebral cortex. So what are the possible receptors? So we know that there is GABA, there is steroid, there is NK1. So we'll give medication according to these receptors. And that is the importance of knowing what are the major key players and the receptors involved. I know that this looks very complex. The receptors look very complex, but when you start practicing it, they are very easy to remember, and even the drugs are very easy to remember. So next, please, next slide. Now, this is a diagram where you'll know what thing triggers which vomiting center. So we talked about three key players, and I think 1, 2, 3, 4, 5 centers in them. So when you are talking about the vestibular nucleus, which is the center in the ear, so we know that yes, movement will cause stimulation of the vestibular nucleus. Then the area postrema or the CTZ or the chemoreceptor trigger zone. So there is biochemical changes, like there could be chemotherapy because of radiotherapy. So it could be activated, and then it sends signal to the vomiting center. Then when we are talking about cerebral cortex, it could be fear, anxiety, memory, or even sensory input. Some patients just, whenever the food is like, they smell the food and they feel nauseous. So even that is like sensory input, and that will activate the cerebral cortex for nausea and vomiting. And when we are talking about gastrointestinal tract, it could be affected by chemotherapy or radiotherapy or surgery if it's done in that region. Then because of gastric factors like gastric stasis, constipation, bowel obstruction, and ultimately it will also trigger the vomiting center, and then it will cause the MSS. So the peripheral pathway is ear and gastrointestinal tract, and the central pathway is the three centers which cause nausea, vomiting in the brain. That is the cerebral cortex, the chemoreceptor trigger zone or the area postrema, and the third one is the vomiting center. And here the diagram also shows which are the receptors which are present in these areas. So if you want, you can note it down later on. And next slide, please. Okay, so now we know what could be the possible cause, what we have seen the history of the patient, and we thought that yes, patient, we are taking the same example that patient has started vomiting before chemotherapy. So we know, yeah, this could be because of anxiety, this could be because of mentation. So now the next step, we identified the pathway and the neurotransmitter involved. So the pathway was cerebral cortex, then vomiting center, so the central pathway. And what are the neurotransmitters involved, like we saw earlier? So now we'll choose the most potent antagonist to that receptor which we have identified. Next slide, please. Okay, so here the receptors are written again, and there is a drug which corresponds to these receptors. So when we are talking about cerebral cortex, the third one, most commonly for these patients, we give lorazepam, dexamethasone. And the patient that we talked about earlier, that is one who has started vomiting even before chemotherapy was administered. So for this patient, patient may be having anxiety, and because of his previous memory and experience, he will trigger his cerebral cortex. So the drug of choice here will be lorazepam. And if the patient has nausea and vomiting after chemotherapy, then I suppose the area postrema or the chemoreceptor trigger zone is activated, because as we saw in the earlier slide, chemotherapy or radiation, it will mostly trigger this zone. But if it's it could also trigger the intestine also, like radiation which is given in the abdominal or pelvic area will trigger the intestines. Chemotherapy triggers both the things. It will trigger the GI tract center as well as the area postrema. So here what we usually do is, you have seen patients being administered with granisetron, ondansetron, aprepitant. So this is the 5-HT3 and the NK1 receptor which is present there, and they are also present in the GI tract. So next slide, please. Yes, so here we can see on the gut wall there is, you can see the second last one, there is 5-HT3 and NK1 receptors. So mostly that is the reason we give granisetron, ondansetron, and aprepitant for chemotherapy related nausea, vomiting. Also, if we see that the patient has constipation, we want that the intestine should move at a faster speed and clear the constipation. So we are going to give something which is prokinetic, um, which will promote the movement. So that's why we give metoclopramide or domperidone. But if there is something like the patient may be having nausea, vomiting along with diarrhea, what does this mean? That the gut is anyway moving at a fast speed, and that's why there is diarrhea also and nausea, vomiting also. So in this case, we would give something which will slower the movement, and that is ondansetron or granisetron. So that is the mechanism. You should know that what do prokinetics do, and prokinetics is mostly metoclopramide and domperidone, while ondansetron is a 5-HT3 receptor blockade, and its main function is to slow down the movement of the intestine. So if you have a patient who has diarrhea and you give metoclopramide or domperidone, so his diarrhea is going to worsen, and obviously it may not have much effect on his nausea, vomiting. But if you have somebody who has constipation and you give him ondansetron, so his constipation is going to worsen and also his nausea, vomiting is going to worsen, because it is going to further slow down the movements of the intestine. So that's why we need to know what receptor is doing what, especially with respect to gut. And I think these two are the most common drugs and most common things that we experience in our practice. But otherwise, later on, you can go back to these slides and you can check which receptor and which drug, so that you know what drug is given when and for what cause and how will it relieve the nausea and vomiting. So next slide, please. And this is also important. So usually, sometimes, not usually, but yes, sometimes when we are giving injections to add on, we'll give metoclopramide and we'll also give buscopan. So buscopan will slow down the movements while metoclopramide increases the movement, and this will have an opposite effect. So we should not combine drugs like this. And we should also not combine metoclopramide with ondansetron, because again, both of them have opposite actions. Then also we should have a look, like for example, combination of metoclopramide and ondansetron, they have opposite action as well, but they also cause cardiac arrhythmias. And if we are using drugs which are like this is a common enzyme which metabolizes the drugs in the liver, and we should take care whether the drugs which we are administering are inhibitors or activators, and they should not increase the QT like there should not be a risk of QT prolongation. And also lots of patients, this is very common. You are administering tramadol, and because of tramadol, patient has nausea, vomiting, and to relieve that, ondansetron is given. So this should not be done, because it will actually block the action of tramadol. So instead of this, what we can do is administer tramadol very slowly. So if you're giving like 50 mg IV or IM, or even 100 mg IV or IM tramadol, it can be given over half an hour to 1 hour, instead of putting it the 100 ml saline, it finishes off in 10 minutes. So rather than finishing it off in 10 minutes, if you extend it over at least half an hour, and if you put it over 1 hour, the patient will not have nausea, vomiting. And still, if the patient has, do not give ondansetron, but rather metoclopramide will be more effective here. So these are the common drug interactions which we should know. And I suppose you all already know about this, and you must be knowing even more about the drug interactions. So I think I should not talk more. So next, let's move on to the next slide. And there are, yes, other non-pharmacological measures also, like there should be, environment should be calm, clean. There shouldn't be any stimulus, like some bad smell coming from somewhere. And the patient might be seeing neighboring patient vomiting. There could be smell of vomit coming out, lots of noise. So even this, like we talked earlier, this will activate the cerebral cortex center and cause nausea, vomiting. Then again, unpleasant odors like smell from wound or smell of vomit, smell of blood. Excuse me. Then there are other things which also help, like progressive muscle relaxation guided imagery, or we can call it like meditation. And there are like TENS also helps in some cases. Then acupressure also helps. And most important, patient should maintain an upright position after meal, because the food or the water that patient has taken, the liquid, overall it will take time to move out from the stomach to the intestine. So as if the patient sleeps, as soon as he eats, he could have regurgitation, he could have acidity reflux, and he could also have gastroesophageal reflux disease. So this will further aggravate everything. So excuse me. So it's important that we ask the patients to sit upright for at least 20 minutes to 30 minutes after the meals. Yes, some of our patients are debilitated and not able to sit that much, but still we should at least encourage a reclining position, maybe 60 degrees or 45 degrees, and make them sit like this for at least like 20 minutes. And small frequent meals will help with those patients who are not able to eat a lot, especially uh, those who are only on supportive care, not receiving any form of treatment, have very reduced appetite, and not able to eat a lot. So small frequent meals will reduce the chances of them having nausea, vomiting, and avoid strong odor and greasy foods. So they will not trigger the centers, and will cause as less nausea, vomiting as possible. So I'm not saying that drugs don't help, but yes, when we combine the non-pharmacological measures, they help a lot. And sometimes we just modify the environment or any of these factors, and there is no need to give antiemetic drugs as well. So I've personally experienced this, and I think this slide is very, very important, and it really prevents, we can avoid giving multiple medications to our patients. Usually the patients are on this thing, that thing, that thing. So there are so many things. So we can maybe reduce one antiemetic by changing these things. And dietary modifications also, they will reduce the acidity, and that's why the nausea, vomiting because of acidity. So next slide, please. Okay, so we have these case scenarios here, and based on what we just learned about the causes and the pathway, everything. So I want you to unmute, don't type in the chat box. And as we talk about like these 8 scenarios, when you click, the cause will appear. So we can start guessing, and when we are done with the guesses, we can see what is the possible cause here. So don't put in the chat box, unmute yourself, and let's answer the first question. So there is a patient who reports colicky pain in the abdomen, and there is distension of abdomen, there is bilious vomiting, and he has not passed stool since 1 week. What do you think could be the possible cause of nausea, vomiting for this first patient? So start guessing and unmute yourself. What do you think could be there? We just learned so many things. Yes, anyone? Please unmute yourself, Amanpreet. Is it possible for her to unmute, or do we have a technical error?
No, ma'am.
Okay.
She can unmute herself.
So you can unmute and answer.
Yes, ma'am.
Yeah. Please. What could be the possible cause in the first case?
Intestinal obstruction.
Any other guesses? Anyone else wants to answer? Do you have anything else in your mind?
Morphine induced.
No, I think the Amanpreet is correct. So can you click just once?
Yes, ma'am.
Can you click just once? Yes, so this is mechanical, and this is intestinal obstruction. So we talked about the mechanical causes. It could be intraluminal, it could be in the wall of the intestine, or it could be extraluminal. So yes, this looks like intestinal obstruction. We don't know what is the cause. It could be anything, but yes, this is a mechanical cause of obstruction. So Amanpreet is very completely right. And this is not because of opioid induced, because patient will not have bilious vomiting. So when, like I explained, the contents of the vomit are important. And when we are talking about the contents, we know that from where the vomiting is coming from. So here it is bilious, that is the obstruction is below the level where bile is released. And that's why all, like, it's green or black colored vomit is coming out. So whenever you are dealing with this thing, and there is also, you can see distension of abdomen. So that means there is obstruction inside. There is a mechanical cause. This won't happen in case of opioid induced nausea vomiting. So what are the guesses for the second scenario? Anyone other than Amanpreet? Now we have like 25 participants here, or I think 23 at least. So anyone else?
I would say it's from the chemotherapy, so medicine induced.
Okay, okay. Any other guesses? So can you click once? Yes, so this is metabolic cause. So the patient, because of chemotherapy, he may have problems, like there could be electrolyte imbalances, there could be anything, and that could lead to metabolic. So yes, we can say this is a metabolic cause, but there could be, it can be because of chemotherapy also. So I won't say exactly because of chemotherapy, there could be other causes as well. What about the third case? Saloni ji, would you like to answer? Okay, Mahima ji, would you like to answer? Nobody?
Mentation, maybe.
Yes, mentation. We have been talking about this for like I've been giving this example. So this is mentation because he received chemotherapy. He has nausea vomiting before even the chemotherapy. Now the fourth one. So a patient has dizziness, vertigo, and head movement causes vomiting. What is the possible cause? This is easy. Okay, so who would like to answer? Shikha?
This is like cirrhosis of liver.
Is it cirrhosis? Patient has dizziness and vertigo, and even if he moves the head, he has nausea, vomiting. Does this happen with liver failure or anything related to liver? You see, there is movement which is causing problems. So what is the possible thing? This is very easy. Has anybody traveled like whenever they're traveling in bus? Sorry? Vestibular, yes. So like we are traveling in bus and we have motion sickness. This is the same thing. Patient may have dizziness and vertigo, and there is the vestibular cause, and that is why he's having nausea, vomiting. So fifth one, very easy. Easiest.
Medication induced.
Yes, this is morphine induced, we know. Next one, sixth one. Patient is a case of CA lung and he has continuous pain over the right part of the upper abdomen. And what is there in the right part of the upper abdomen? What organ? And he also has jaundice. See the last word. So what is the possible cause in this scenario?
Chemotherapy.
Not chemotherapy. No. Not metabolic. Yeah, sorry. What is there in this right upper abdomen? What is there?
Liver.
Yes. So what could be the problem here?
Liver metastasis.
Yes. So somebody said metabolic. So it is because of metastasis. So you see there is patient has CL lung. So which are the most common sites where metastasis happens. So liver is the most common site. There is brain also, and patient is complaining of pain. So there has to be some problem in the liver. He also has jaundice. That means this is a case of nausea vomiting because of metastasis. So the seventh one, any guesses? Okay,
Virus.
I think seventh is the easiest. Uh, yeah, patient has fever and diarrhea and also nausea vomiting. So what is the possible cause here?
Microbes.
Yes. So this could be some sort of infection. And the eighth one, so I think, is it visible to everyone? The eighth slide, is it visible completely? Yeah, it could be anything, cholera, typhoid, or like any type of infection can be possible. Is eighth one visible to everyone? Can you read it
Yes, ma'am.
completely? Okay. So can you guess the possible cause here?
Mucosal.
Yes, mucosal. Correct. That's correct. It is definitely medication induced also, but here mainly because this is diclofenac, this is NSAID, and we are talking about acidity mainly here. So medication would be a general term, and but here we are mainly talking about acidity, so it would be more of mucosal type. But yes, you can talk about it is because of medications also. That is also entirely correct. So I think maybe you can go back to the previous slide where no, where you can, when you this presentation ends, you can go to the previous slide where we have mentioned the 10 causes of 10 M's for the causes of nausea, vomiting, and that ways you'll be able to, whenever you see a case scenario, you'll be able to guess nicely which is the possible thing which causes nausea, vomiting, and that way you can relieve the patient. So coming to the next topic is this is constipation, and like there is a like constipation is very common. Every other patient you see might turn up with constipation, and we have to give like laxatives to most of our patients because of this. And there's also a term called as obstipation associated, where the patient in along with failure to pass stools also has failure to pass gases. So you should just know this term, that there is a term called constipation, and there is a term called obstipation. So next slide, please. So we have actually a definition for constipation. We can just like there are patients that have they say that it's 10 a.m. that and still they have not passed stools, and they are very anxious that they are constipated. So or there are patients who feel that it's been 2 days and I haven't passed stools, and oh god. So then there you get to see such patients, and there are old people also who are very anxious. So you cannot, there is a specific definition for constipation. There is a specific criteria for it. And the first one is that 25% of time, so 1 out of 4. So there has to be straining. Patient is not able to pass stools without any effort. Then the stool is lumpy or hard in 1 out of 4 cases. Then there is a sensation of incomplete evacuation or anorectal obstruction or blockage, again 1 out of 4 times. And 1 out of 4 times the patient may use manual maneuvers to facilitate the removal of stools, like for example digital evacuation. So 1 out of 4 times. So we should have 1, 2, 3, 4, 5. 5 of these 1 out of 4 times. And there have to be fewer than 3 defecations per week. And the next criteria, next click please. Yes. And patient is not able to, or he needs to use laxatives most of the times to pass stools. And also we should rule out that there is no cause of irritable bowel syndrome. So this is like the for 1 and 2 is like, okay, if you want to read further, then you can go and look into the causes of irritable bowel syndrome and the symptoms so that you don't confuse it. Usually the patients of irritable bowel syndrome, they have diarrhea and constipation and alternating, and they have very irregular bowel habits. So, and usually this lasts for like at least 3 to 6 months. So our the constipation is not like that. Usually only with fewer than three defecations per week. So this is fine. So you need to remember the first and the second one. Just for definition purpose, I've given three, but you can ignore it if you want to. Next slide, please. Right. So here are the causes of constipation in palliative care. Most common, most common diet-related patients don't take water. So you'll ask them how much water do you take. They'll say yes, yes, we drink a lot of water. But then again, ask them how much exactly. So then you'll understand that they drink only four glasses of water every day. So one glass is approximately like 150 to 250 ml, not more than that, and 4 glasses is like 1 liter. So with 1 liter or like half liters, the patient are not able to pass stools properly. So there has to be adequate water intake. So in most of the cases, you should just advise the patient if there are no other contraindications, just have a look if there is no kidney problem or the patient has not been told to reduce or keep his water intake low. But otherwise, you can advise the patients to have a lot of water, like at least 2 liters per day. And if the environment is very hot, I usually ask them to go up to like 2.5 to 3 liters minimum, and that helps with constipation. Then obviously fiber intake, and when you are advising fiber intake, just see if there are any contraindications. For example, those patients who have bowel obstruction, or those who are at risk of ending up with bowel obstruction again and again. So only in those patients we usually don't advise fiber intake, because fiber will get stuck and cause bowel obstruction. But otherwise, for most other patients, water and fiber, even these two things, they will help and no drugs are required. Then coming to the second one, opioids, for example, morphine, they cause constipation. And if the patient is on morphine, only water and fiber is not going to help. We need to prescribe laxatives in this case. But yes, water intake will help, only laxatives will not help. Then those patients who have hypercalcemia, hypokalemia, so these are, we are talking about metabolic disturbances. So after chemotherapy, patients come with these side effects. Patients who have diabetes, even they have dehydration. So all of these patients, and also we have mentioned here that because of vomiting or diarrhea, so the patient has been vomiting and vomiting so much that all of his sodium, which is secreted in the stomach, it has like gone out, and he is in a state of sodium hyponatremia, and or he has been having diarrhea, so he's anyway dehydrated. So this will lower down the content of water and will cause renal failure, and also will cause constipation. And we have patients who may have some cerebral tumors, or because of some spinal cord involvement, they may have constipation. Then we are talking about pelvic tumor mass, which is compressing. So I talked about causes of bowel obstruction earlier, intraluminal, extraluminal, and which is because of the wall of the intestine. So any structural abnormality which is affecting either of the three can cause constipation. So pelvic tumor mass can be compressing from outside. There could be radiation fibrosis which is affecting the wall. Then there could be piles, hemorrhoids, like hemorrhoids or fissures, or perianal abscess, which is like blocking the rectum or anal area, or patient will have so much pain passing stools that he may not be able to pass stools at all. Then yes, in India we do have sometimes such issues, that there is lack of privacy, or a patient has to go to a common toilet outside the house. Patient is of so much advanced age, or he's not able to independently go to the toilet, or like patient is because of these things, the patients, they sometimes choose to not eat so that they don't have to go to the toilet a lot or not trouble others. They do have these things like these social inhibitions, and they end up with constipation and other complications also. And there are others who have like decreased mobility, and because they're most of the time sleeping sedated, or they may be having depression, and because of the medications which are antidepressants, they may have side effects of those medications and end up with constipation. So you should also have a look at the lifestyle related issues. And I would say the most common thing, if ever you see a patient with constipation, is firstly water, proper diet, if the patient is on morphine, and thirdly lifestyle related. Like these are so common and so simple four things that mostly in my patients I ask them to have a lot of water, eat properly, and they just start they get over the constipation, and I don't need to give them any laxative also. And sometimes I just ask them to move around, exercise as much as possible. Not everyone can do it, but yes, but even these things, they help a lot, and you don't need to go for laxatives every time. But for opioids, I would say laxatives will have to be given, and along with that, adequate water intake is also important. Next slide, please. This chart is there, and though when I first saw this chart a few years back, I was like laughing that, okay, do we have such things also, where we are looking at the shape and the hardness of the stool and description of stool? But yes, this chart is not we don't use it very commonly, but when I was in a GIOPD, they did use it, and it helps a lot to know what is the shape of the stool, so that there are patients who just say, I am having diarrhea, I'm having constipation, and when you ask them with reference to this chart, you end up knowing that no, perhaps the patient is not constipated or not having diarrhea. So this helps to a certain extent, and you can use it if you want. Next slide, please. Next, please. Okay. So whenever you are talking about management, whenever we talk about management of anything, history is important. History always helps us know what is the possible cause for that problem. So like we talked about history in case of nausea, vomiting, we'll talk about history in case of constipation also. And again, these all things will help us, like if there is
Excuse me,
something.
ma'am.
Yeah. Hello.
Yeah, can you speak a little louder?
Yeah. So in this case, all these factors will help us find out what is the possible cause. We in the previous slide we just saw the possible causes, and that ways we'll know what is causing it and how can we relieve it. And digital rectal examination is important because patients come with impacted stool and piles lots of times. So there could be possible obstructing masses also. So make sure we do that. And this is important, even though it may sound disgusting, but it helps a lot. Very simple thing, and it helps clear so many problems. And next slide, please. Right, so these are the management drugs which we use. So the surface wetting agents, I'll just explain their functions shortly. So they mostly, the surface wetting agents, they act as detergents, and they reduce the surface tension, and they allow water and fats to penetrate the hard and dry feces. So that way the feces become soft, and they are the patient can pass them easily. When we talk about osmotic laxatives, so they retain water in the gut lumen and increase the fecal volume. So you get the difference between the two. The surface wetting agents will make the water enter inside the feces and make them soft, and the osmotic laxatives, they will just increase the water content of the intestine and generally the content of the stool, and that way the fecal volume, when it is increased, it will be able to pass out from the intestine. And when we are talking about stimulants, so there are two types. one acting on small bowel and large bowel, and the other one which acts only on the large bowel. So with direct contact with the submucosal and the mesenteric plexus, which is present in the intestine, they initiate rhythmic muscle contractions and increase intestinal motility. And there are lubricants which coat the surface of the stool to make it more slippery. So they don't soften the stool or don't increase the volume of the stool. They just coat it and make it more slippery, and thus easier to pass out. And the last one is bulk forming agents. So they increase the fecal bulk through water binding and bacterial cell mass. But I would say the role of bulk forming agent in palliative medicine is very limited. Our patients may have obstruction also, and usually these agents are not very effective. They are good for those normal people, older people, who want to have like fiber. Spagula is like commonly used, but otherwise I wouldn't recommend, or I personally haven't used these for palliative care patients. So most commonly we use there is lubricants. Liquid paraffin is part of Cremafin Plus. There are stimulants. Bisacodyl is used commonly. Sodium picosulfate is part of Cremafin Plus. And we use lactulose syrup commonly. We use magnesium commonly. And next slide, please. And there are suppositories and enemas also. So bisacodyl suppository acts in the same way. The drug is the same. And docusate also will act in the same way. And basically the mechanism is all same. Glycerol is a glycerol, and there is osmotic microenema. So the mechanism is all same. The only difference is rather than giving them orally, we are putting them inside the rectum or the rectum, and we are using them mostly for impacted stools, which cannot be like after digital evacuation, you have to sometimes remove the impacted stools. So something which is like you have to put something inside the rectum, and that like all the feces which have accumulated can come out. So that is the only difference, and this also helps. So it just depends on clinically what is the situation of the patient, what is the cause of constipation, and which one to use. But otherwise the mechanism is the same. Next slide, please. Yes, like we had non-pharmacological measures for nausea, vomiting. Similarly here, just as we get up in the morning, so peristalsis is maximum upon waking or after meals within like 1 hour. So maybe we should use that time, and we should encourage fluids as much as possible, like I emphasized on earlier as well. And like proper positioning, it's better to like, I don't know how many patients will be able to sit over a commode or toilet, but yes, these things help. Next slide, please. This is an important issue because we have so many patients on opioids, and we get opioid induced constipation. The most important thing that we should know is why opioids cause constipation. So they cause constipation because of three important things. Firstly, they cause the intestinal or you can say the intestine to contract. So that is first thing. Then they reduce the intestinal activity, so the intestine is contracted and moving at a slower speed. And thirdly, they resorb the fluid and electrolytes, so the content of the intestines have reduced. So that's why there is more constipation. And mostly here we give a stimulant laxative, so that which increases the propulsive activity of the intestine. And again, we should titrate the dose according to the response given by the patient. So commonly used is bisacodyl, and there is sodium picosulfate, which is present in Cremafin Plus. And whenever the patient is on opioid, he or she must be prescribed a laxative, because he will end up with constipation if no laxative is given. And so this is something which has to be kept in mind. If there is an opioid, there has to be a laxative along with it. Next, please. So we get paraplegic patients, and if the lesion is above L1 or T12, so the GI tract is spastic and there is preserved sacral reflex. So it will respond to digital stimulation, and mostly the patient is able to pass stools. Even if the patient is paraplegic, he won't have a lot of problem with constipation, or even if you give some form of laxatives, he'll be fine. But if the lesion is below T12 or L1, the GI tract will be flaccid. So whatever amount of laxatives you're going to give, it is not going to cause any effect because his intestines are not acting. So like even if the content of the intestine is increased or it is being stimulated, the intestines are not able to move and pass out stools. So in these cases, manual evacuation of the rectum has to be done. And what we can do for both of these patients is we can give laxatives when they are acting, like for lesions above T12 or L1, and dietary modifications help. Then there is a thing called a spinal bowel regime. This is we use suppositories for these patients and give them hot drink to stimulate reflex, and at the same time we digitally stimulate the rectum. So when this is done regularly at the same time, the bowel gets used to it, and this is done for patients who are paraplegic. So you know what is spinal bowel regime now. Next, please. Yeah, so I think that's it. So I think I've used some time from Amanpreet's case presentation. We can start that, and after that we can take any questions.
Okay. Thank you, ma'am. If you have any doubts, please unmute yourself and talk, or you can put that question in the chat box. In the meantime, we can move on to the case presentation. Amanpreet?
Yes, ma'am.
Yeah, okay. So to you.
Good evening, everybody. Myself, Amanpreet. I'm working as a physician assistant under medical oncology department in CMC hospital. So today I'm here to present the topic gastrointestinal symptom, vomiting, nausea, and constipation. So today I'm presenting case. There was a 68 years old male diagnosed case of adenocarcinoma prostate in 2017. Status post bilateral orchidectomy in 2017, hypertension, and diabetes mellitus type 2. So he was presented with main complaints of constipation, pain in lower abdomen, nausea, vomiting, decreased appetite, and generalized weakness. So history of illness was, he was diagnosed in 2017 as adenocarcinoma prostate. Orchidectomy was done in 2017. So he had hypertension also. After that, he was presented to us in 2021. So he was started on palliative chemotherapy with injection docetaxel. He received 3 cycles from August 2021 to September 2021. So in October 2021, his re-imaging was done. He had disease progression. So he was started on cabazitaxel from October 2021 to November 2021. After that, his PSMA PET scan was done. Again, he had disease progression. So in November 2021, his liver biopsy was done. So that showed small cell carcinoma features. After that, he was put on etoposide and carboplatin. He received 5 cycles of that. So when he was presented to us, he was conscious oriented. Performance status was 4. There was no pallor, cyanosis, clubbing, or icterus. Chest showed bilateral air entry, but right side air entry was decreased. So CVS and CNS status was normal. Per abdomen was mild tense, tenderness was present, bowel sound was present. So by biochemical parameter and hematological parameter was also normal. Echo was done in 2021. That was also normal. So when he got discharged, he was put on Arorap, morphine SR 20 mg BD, Perinom 10 mg BD, paracetamol, TDS, Nervide, Calgro, Silodol, Angizar, Drotin, syrup Movicol, and metformin. So his main concern was pain, abdomen, and fullness. His appetite was decreased, vomiting, constipation, and due to his poor performance status and weakness, he was unable to mobilize. So summary is he was post multiple line of chemotherapies. That time he was on palliative care, presented with pain, abdomen that is related to disease, was put on morphine, had constipation. Constipation was morphine induced. He was put on laxative and antiemetic agents. Then family wanted to keep him on comfort care at home. So points to be discussed. First point is, how can we improve his quality of life?
Can you read it out?
How can we improve his quality of life?
You can read it all the questions, then we can discuss.
Okay, ma'am. Second is, how can we help him in avoiding constipation as he was on morphine? Third is, how can we give him psychological support, him or his family? Yeah.
Thank you, Amanpreet, for the presentation. Anybody need any more clarification regarding this patient story? Please answer. So otherwise, we can move on to the discussion points. So I hope nobody need any more clarification regarding this patient story. The patient story is clear to everyone. So we can move on to the discussion points. So we would like to hear from the participant side. So how will you? We all learned many things today from ma'am's presentation. So so how will you improve this patient's quality of life? Please unmute yourself and talk. Amanpreet, what are the main concerns right now? Where is he right now? He is at home or hospital?
Ma'am, he has expired a few days ago.
Okay, he has expired. Okay, sorry. So anyway, we can discuss. if you see these type of patients in your settings, how will you improve the quality of life of this patient? How will you help? Any idea? Any suggestions? So we would like to hear from the participant side. I'll call you. Salome, how will you improve this patient's quality of life? Please share your thoughts.
So trying to solve the problem with the constipation, because that also limits the appetite, and offering him whatever he would like to eat. Yeah, so it's, definitely looking at the constipation, at the nausea, what the causes are. I think it's also metabolic because he's got liver metastasis. So looking at treating the causes of nausea and constipation.
Thank you, Salome, for the contribution. Anything else? Anybody wants to add anything? Madam?
Can we come to the medications part first? Just that
Yes.
slide.
Yes.
I can see that the patient is on morphine, and to relieve his constipation, there is like the drugs which are there is, one is Perinom, then there is Movicol, and also there is Drotin. So Drotin is like antispasmodic. Was the patient having like colicky pain in the abdomen? Why was Drotin added?
Yes, ma'am. He had pain abdomen.
So this is actually Drotin as an antispasmodic. So it is going to reduce the action of his intestines, and that will contribute to constipation. And Perinom is like opposite acting. So Perinom and Drotin here are like two opposite acting drugs. So I think the only thing that is acting is Movicol. So maybe we can add something more to it. Movicol is a good laxative, but maybe we can add stimulant also. Like I don't know if the patient is having colicky abdominal pain. Is there any specific reason for his colicky pain? Are there like intestinal peritoneal metastasis or anything related to bowel obstruction, or was it like temporary only?
No, ma'am. After releasing constipation, his pain was better.
Okay. So maybe this Rotin, I don't know, can be stopped if he's not on uh, he's not having spasmodic pain continuously. And otherwise, Movicol and Perinom should help. Mobilization should help. And also, I see his sodium level was slightly lower, 127. So if that can be increased, it will also help with fatigue and reduced appetite that the patient may have. So I think that like these are my inputs. And yeah, there is an antacid somewhere. Like I don't know, is there?
No.
Anyway, he's on so many drugs, so there should be some antacid also, maybe pantoprazole, omeprazole, or Rantac, whichever is suitable. He's on so many things, so Rantac should be more
He
suitable
was on
because
PPI.
Sorry, he's on PPI.
Yes, ma'am.
Okay, okay.
I will have.
Otherwise, I think this was a very good case and it was presented very well. So I guess we have a good case presentation. That's like, these are the inputs I have. If anyone has any questions or has anything more to add to this case, you can you can unmute yourself.
Any other questions? So I hope your presentation is clear, ma'am. So nobody have any questions regarding this presentation. So regarding this patient story, as ma'am said, always try to identify the cause. So if the patient is complaining of that constipation, you can identify the cause, maybe drug related or anything. So maybe metabolic related. So you have to identify the cause first. If the patient is complaining of nausea, vomiting, also you have to try to identify the cause based on the, after that, we have to understand that how to identify the cause and how to manage. So each from that nausea vomiting class, you have understand that each that particular symptom is that management is that particular medication is control particular work on particular receptor. So we have to understand that. Based on that, when a patient's when a doctor prescribes for such particular medication for the patient's that problems such nausea vomiting, so you can understand, okay, whether that medication is helpful or not. So if the medication is not wrong, you can talk to the doctor directly, but not in authoritative way. So you have to communicate. So can this medication is work on something like that? You have to communicate proper way so that we can change the drugs if they want. They can change the drugs. So our aim is to improve the quality of life of the patient and the family. So once the patient's that problems, the symptoms, signs and symptoms reduce, definitely we can improve the quality of life of the patient and the family. So always try to identify the cause, and based on that, we can able to manage their symptoms. That way, we can improve the quality of life. So thank you, ma'am, for the wonderful presentation. We have learned a lot from you today. Thank you, Amanpreet, for the wonderful presentation. Thank you. We will meet next day.
Thank you, everyone.
Thank you all. I will see you on the next class. The feedback will be shared on your WhatsApp group. And one more thing, everyone should turn on their video once in a while in your classroom. As if you are not likely to turn on your video, you will be considered absent from next class onwards. If you have any solid reason, you can update it in the group or in the chat option also. Thank you all. Bye.